Okay, hey everyone. I want to make sure that this is recording. Yeah, we were recording. Okay. So we're going to go over the weakness. Oh my gosh. There we go. We're going to go over the weakness scenario right now, and I'm going to try to make this quick. This is like my third take of this, so I don't want to waste your time. Oh, I said some dumb stuff on the last one. Wow. Yeah, it's better this way. Okay, real quick, let's go over this. So we have a 68-year-old male who's feeling weak and having some secondary complaints of chest pain and shortness of breath. This occurred suddenly while he was cleaning gutters. Let's see. Patient was cleaning gutters in the house. Began to feel weak and short of breath. During the physical assessment, the patient describes a cramp encompassing his arm, shoulder, and chest. Open airway, breathing's rapid, non-labored. Circulation strong, regular pulses. Skin is pale and clammy. Vitals, heart rate, a little high, but not bad. Blood pressure, this is way too good for someone this old and this sick. But whatever, they got a stable blood pressure. I would expect this to be more, just in my experience, I would expect that to be more in like the 140s or 150s, but that's just me. Respirators 26, pulse ox 98%. I'd imagine that's on room air. Ventital 38, whatever. Sinus rhythm on the monitor. 98 blood sugar. Okay. And let's see. Feeling weak and short of breath during secondary assessment describes the cramping. Allergic to sulfa. Takes lisinopril. He's got high blood pressure. And 4 hours ago, he ate tomato soup and grilled cheese sandwich. Patient was clearing the gutters. Okay, so he's clearing his gutters when he began to feel a cramp in his left arm. By the time he had climbed down the ladder, the cramp had encompassed his shoulder, arm, and chest, and his wife called 911. But the funny thing is that we're dispatched for weakness, not for an arm cramp or cramping feeling in his chest. So, look, it's real life, right? Like real life, we go on people that change their story all the time. Even in the middle of their story, they'll change it. And so you can't get too hung up on it. So right now, we're not exactly sure what's the worst this guy's feeling, but we're dispatched for weakness. So we'll just go with that. All right. Now, I'm going to go over to my skeleton. I don't write this skeleton for myself at work. This is just for you, to help you, to act as a guideline, to help you write a good narrative. And if anyone's done this with me, I had a bunch of you on today. If you've watched another video, I think I made one other video with this format. You kind of fill in the gaps and then you delete the skeleton. And there you have your narrative. Okay, so let's write one together. And I'm gonna go get my coffee because I made coffee real quick. So give me 1 second. Pause recording. Okay, we're back recording. I got my coffee. Just get a little sip here. Oh yeah, it's good. It's only 7:45. Dispatch reason. EMS is dispatched to a single family home for a male feeling weak. That's it. It's just a good intro, right? We got it. Go away. Let's get this out of here. These little things distract the living daylights out of me. All right. Patient is complaining of feeling generally weak. Chief complaint. It's that simple. Patient states the weakness began suddenly, or we'll just say began while he was, no, it's a heart attack. Began suddenly while he was cleaning out gutters. Not cutters, gutters. So provokes, so weakness, we really think, and I'm not sure if anything, it's not like he's going to say, yes, when I exert myself, the weakness gets worse. He's not going to say that. People don't talk like that. So what he might say is he's rested now. So he might say, patient reports feeling slightly better after resting, but is still feeling very weak. I like to qualify after resting for several minutes. Quality. Now, we're not going to say much about quality for weakness. You just feel weak, right? Radiates. Weakness doesn't radiate anywhere, right? Severity. Can you rate your weakness on a 1 to 10 scale? You're probably not going to get that. They're not. What are you talking about? I just feel really weak. So I probably wouldn't write much for that. In time. How long? Yeah. Patience. You could say weakness. 20 minutes ago. There you go. Radiates. If you ask radiates question, you can't say like, "Hey, are you feeling weak anywhere else?" One thing you are going to ask is, "Do you have any other? Are you feeling anything else?" You're going to say, "Patient also reports feeling short of breath and has a cramping." Now we're going to use quotes because he describes this as cramping. It's a cramping sensation or cramping pain in his left chest, left shoulder, and left arm. Patient states the shortness of breath and cramping began shortly after he began feeling. There are some secondary complaints, right? Pertinent negatives are very important. Patient denies he's not having a headache. And again, I start from the head and work my way down. Headache, dizziness. Now, he does have chest discomfort, so we can't say he denies chest discomfort. He's feeling short of breath. We can't say he denies feeling short of breath. He's not feeling nausea, and he hasn't been vomiting. Abdominal pain. That's my period, because I like to separate medical complaints specific to right now with other things. Patient denies. I always ask about recent illness or trauma. Okay, period. Patient denies recent medication changes. Those are very important to ask about. Patient denies recent stress. The reason I put this into my narratives, you don't have to. I'm just telling you what I've learned over about, I think I've been doing this 10 years now. What day is it? What time is it? What year is it? Jeez, hang on. It's 2020. It's, it's 2020. Yes, I began my job 10 and a half years ago now. So I've been doing this for 10 and a half years. Anyways, I always ask these questions because you'd be amazed at, oh yeah. I just came off my my blood thinner like a week ago, or well, yeah, I was in the hospital last month for a stroke. Really important information. I've had stress, even where like people have been enduring incredible stress, and they'll minimize it. They'll just accept it, right? So significant stuff. Okay. So that's that. Allergies, penicillin, medications. He takes lisinopril, I believe, with HCTZ. That's hydrochlorothiazide. That's why I call it HCTZ. Medical history, go away. Medical history is hypertension. That's what that stands for. Last food, patient. Tomato sauce, tomato soup. Me and my brother used to eat our grilled cheese growing up, dipping that stuff in applesauce. It was amazing. My grandma made this applesauce. It was so good. Okay, so let's real quick. I'm going to pause this. Wait, pause. Now we'll keep recording going. I'm going to show you what we're going to do. We're going to remove the skeleton. Oop. Remove that skeleton. Remove that one, or all those. Revokes. Remove. Set. You can do this whatever order you want. Here we go. If you want to leave stuff like dispatch reason in, if you want to organize yours, like by identifying what the subjective is, you can do that. You can leave that in if you want. I'm going to leave in past medical history just so it shows what this is. You can do that. I'm going to delete, erase mine because I wouldn't want it in there. And I would just have it maybe like that, right? So patient is complaining, EMS is dispatched to a single family home for male feeling weak. Patient is complaining of feeling generally weak. Patient states this weakness began suddenly while he was cleaning out gutters. Patient reports feeling slightly better after resting for several minutes, but is still feeling very weak. Patient states the weakness began about 20 minutes ago. Patient also reports feeling shortness of breath and has a cramping feeling in his left chest, left shoulder, and left arm. Yes, I specified all lefts. Patient states the shortness of breath and cramping began shortly after he began feeling weak. Patient denies headache, dizziness, nausea, vomiting, abdominal pain. Patient denies recent illness or trauma. Patient denies recent medication changes. And patient denies recent stress. One thing I would probably edit right here is I would take out this line. Patient states the weakness began about 20 minutes ago. I would put it up here about 20 minutes ago. There we go. We just made it a bit more efficient. All right. There you go. All right. So let's go on to our objective. Okay. So patient is a what? Patient is a 68-year-old male. Found where? Found sitting inside his home with wife on scene prior to arrival. Found sitting inside, I might say sitting on the couch in the living room inside his home with wife on scene prior to arrival. So there we go. We got the location in there. AO times 4, let's say he's alert and oriented, with anxious behavior. I'm a big fan of behavior. You've heard me say that before. It's anxious behavior. Well, there, I took care of behavior. Breathing is non-labored, however, patient breathing is rapid. Word with no abnormal sounds. Lung sounds clear and equal. Whoops, equal. Circulation, we're going to check pulses. Strong, regular, radial pulses. We're going to go skin color. Skin, I think it said skin color might have been looking a bit funky. Hey. Skin is pale and clammy. Yeah, that's not good. That's worthy of putting in here. Skin is pale, clammy. Patient denies. Okay. So let's go ahead and take the skeleton off of this. So maybe in my skeleton, I can do an updated one where I just do level of consciousness and behavior together, and the position and location together. Here we have it. Pale, so now let's do the assessment. Pale skin, pearl, good enough for me. Neck, normal, neck spine is normal. Patient denies falling. Chest equal, rise, fall, clear equal, lung sounds. Abdomen is going to be soft non-tender times 4. That's all I'd say for that. Extremities, CMS intact, times 4 cap refill is less than 2 seconds. I never check cap refill, and I don't write CMS. Do this for your narratives here, but I like to tell you what I do out in the field. So vitals, we're going to put in vitals from here. 128.82, 96, 26. 128.82. VP 128 over, what do you say, 92? It's a small blip. Something like that. It doesn't matter. Heart rate is 96. Respiratory rate is 26. SpO2 is 98% on room air. Intel CO2 is 50. I think it's 55. Let's call it 50. Who cares? VGL is something not bad, 92. I know it might be different. It's okay. It's true. It's okay. It's okay. Okay, now our plan. On scene, I always start this the exact same way. Patient is assessed on scene with what? What do we do to assess them? With vitals, SpO2, VGL, and we're going to do a 12-lead EKG. Sinus rhythm, and we're going to say that this guy's having a heart attack. Let's do that. Sinus rhythm with noted ST elevation and V, let's say V2 through V5. Okay. Oh, I can't do that to you guys. You should do that. You should write this and put this in your narrative for Dave to read, see if he's checking these things. So this guy's having a heart attack. Let's say he's having the big one, right? So this is telling us that he's got an elevation. Pads placed. Say, what do we give? What do we give for heart attacks? We give aspirin, right? 324 milligrams PO. That means per oral, because you got to chew that up. Let's read this real quick. See, he's having an MI. So, okay. And nitroglycerin, 0.4 milligrams sublingual with no change in chest cramping or SOB reported by patient. So what's really important is any STEMI, if you know it's a heart attack, and not everyone having chest pain is having a heart attack, it's not it. But if out in the field we see that someone's actually having a heart attack, those paddles, the shocking pads go on right now. Right now, first thing you do, I'd be like, okay, looks like you might be having a heart attack. This is, my partner Joe's going to put some big sticky pads on your chest, and if we have to shave your chest, we're going to do that too, just so we're ready in case you need some help. And I'm going to give you some aspirin, right? So we've already checked he's not allergic to anything, so I'm going to give you 324 milligrams of aspirin. I want you to chew this up. Don't just swallow these pills, chew them up. Because when you chew them up, they enter your bloodstream through your cheek a little bit, and they get absorbed much faster. And that aspirin is very important, right? And then the nitroglycerin, 0.3 milligrams, and that's either a tablet or a spray under the tongue. You can do it on the cheek too. And a lot of people, you'd be amazed at how many people can't lift their tongue up to the roof of their mouth. They can't do that. They'll stick their tongue up before they actually touch the roof of their mouth with the tip of their tongue. It's really weird. So don't take forever. If you got to put your fingers in there and shove that little tablet underneath their tongue, tell them not to bite you, but get her in there because it's very important. Okay, so transfer the rig. Patient is secured to stretcher and transferred rig during transport. Patient is transported to, let's say we're going to go to United ER with vitals. And EKG monitored. This request STEMI response. Patient rests calmly, or not calmly, during transport and continues to complain of feeling weak and chest cramping. Now, let's say we give them another dose of nitro. Nitroglycerin, 0.4 milligrams sublingual, repeated with no change reported. Now in an ambulance with me, I'd be doing an IV. Oh shoot, we might want to give this guy some oxygen. Yeah, on scene. Let's give him some oxygen on scene. ASA 34, O2 4 liters per minute nasal cannula. Whoa, if you guys make a mistake, if you realize you've made a mistake, either in your narrative or in your scenarios, fix it. Out in the field, you won't just give up and be like, oh shit, I'm an idiot. You'd say, oh shit, I'm an idiot. Let me fix that for you. Let's go back in time to on scene and put some oxygen on it, right? Okay, so on arrival, patient is transferred to ER1. I believe at United it's an ER1, and care to and lifted to patient care transferred to ERMD and RN. Okay, let's take the skeleton away. Let's look at what our narrative's done, or our plan. It tells what we did on scene. It tells how we got to the truck with this patient. And it also says that we secured this patient to the stretcher, right? Oops. Oh my gosh. So it tells how we secured him to the stretcher. We got him there safely. And it also talks about what we did en route to the hospital and how he responded to that. It says that we request an emergent response or a STEMI response. And it tells us that the patient did okay, that the patient survived, right? And then it says that we gave him more nitro. Nothing changed with the nitro. We monitored the vitals, we monitored the EKG. And then upon arrival, we got him to a higher level of care. It's really important. So there we go. There is our patient care report. Again, this seems like a lot. That's why I'm walking through this with you. This takes a long time to learn how to write this well. My last trainee took us about 5 weeks of really working, focused on every narrative she wrote to get her to do something that would resemble something very effective. Oh, we'd also put in our backup vitals, but I don't really care. You can do that. So that's it. That's for the weakness. I hope this helps. Let me know if you guys have any questions about this video. That's what I got for you. All right. See you later.